My total testosterone was 520 and my doctor told me I was fine. 6 months later, I finally got free testosterone tested. It was in the bottom 5% for my age. That was a viewer comment last month. And it points to something that most men over 40 don't understand. Total and free testosterone are different measurements that answer different clinical questions. Today, we're going to explain what each one actually means, when you need both, and what the evidence says about the factors that shift free testosterone independent of total. Here's the common belief. You go to your doctor, get your testosterone checked, and if the number comes back above 300 nanograms per deciliter, you're told you're normal. End of conversation. The problem is not that your doctor is negligent. It's that the standard first-line test, total testosterone, measures everything in your blood, the testosterone that's freely available for your cells to use, the testosterone that's loosely bound to a protein called albumin, and the testosterone that's tightly bound to a protein called sex hormone-binding globulin, or SHBG. Here's the breakdown. Roughly 2% of your total testosterone circulates as truly free testosterone. About 38% is bound to albumin. This binding is weak, and the testosterone can detach easily, so it's considered bioavailable. The remaining 60% is bound to SHBG. This binding is much stronger, and while it is not permanent, SHBG-bound testosterone is generally not available for your tissues to use. So when people say free testosterone is the active form, what they mean more precisely is that the free and albumin-bound fractions, together called bioavailable testosterone, are the portions your cells can readily use. The SHBG-bound fraction acts more like a circulating reservoir. This matters because SHBG increases with age in men. A 2023 study confirmed that liver SHBG production rises with aging. That means a 55-year-old man and a 30-year-old man could have identical total testosterone levels, but the older man may have significantly less bioavailable testosterone because more of it is bound to SHBG. Now, what does the evidence actually say about the clinical importance of free testosterone? A 2025 study found that calculated free testosterone, compared to total testosterone, is more closely associated with lean mass, muscle strength, power, and physical function in older men. A separate peer-reviewed study confirmed that calculated free testosterone is a better predictor of symptoms of clinically low testosterone than total testosterone in middle-aged men. And there's a dimension. A study published in a leading endocrinology journal found that low free testosterone predicts mortality from cardiovascular disease in men, even after adjusting for age and other risk factors, with a hazard ratio of 1.62 for men at the lower end of the free testosterone range. But here's the nuance most channels skip. The Endocrine Society's 2018 Clinical Practice Guideline recommends total testosterone as the initial screening test. Free testosterone measurement is recommended when total testosterone is borderline, between approximately 150 and 350 nanograms per deciliter, or when there is reason to suspect an SHBG abnormality. These reasons include obesity, aging, liver disease, thyroid disorders, or use of medications that alter SHBG, such as anticonvulsants or glucocorticoids. This is not a conspiracy or a blind spot. It's a rational tiered approach. Total testosterone first, then free testosterone if the clinical picture doesn't match the number. The problem is that many men don't know to ask for the second step, and some clinicians move on too quickly when the total number looks reassuring. So what causes SHBG to be elevated? The main drivers are aging itself, low insulin levels. Paradoxically, insulin suppresses SHBG, so insulin-sensitive lean men often have higher SHBG, liver disease, certain medications, and low androgen levels. Factors that lower SHBG include obesity, insulin resistance, type 2 diabetes, and use of androgens. Notice something important here. The original script told you that a stressed or fatty liver overproduces SHBG. The evidence actually shows the opposite, always. Sheesh, fatty liver disease and insulin resistance are associated with lower SHBG, not higher. Higher SHBG is more typically seen in lean, aging men with good insulin sensitivity. The physiology is more complex than a simple liver stress narrative. So what should you actually do with this information? Step 1. Know when to request free testosterone testing. If your total testosterone comes back between 150 and 400 nanograms per deciliter and you have symptoms, persistent fatigue, declining muscle mass, low libido, depressed mood, ask your doctor to also measure free testosterone, calculated from total testosterone, SHBG, and albumin, or bioavailable testosterone. Also request SHBG itself. Knowing your SHBG level tells you whether the total number is giving you an accurate picture of your hormonal status. If your total testosterone is clearly normal, say above 500, and you have no symptoms, additional testing is unlikely to change management. Step 2. Address the factors that actually influence SHBG and free testosterone. The most evidence-based approach is not a liver detox supplement. It's managing the metabolic factors that shift the balance. If your SHBG is high, this is common in lean, aging men. Options are limited because high SHBG in this context is partly a normal physiological change. If symptoms are present and free testosterone is genuinely low, this is a legitimate indication for discussing testosterone therapy with your physician, because the problem is not that your body isn't making enough testosterone, but that too much is being bound up. If your SHBG is low, this is more common in men with insulin resistance, metabolic syndrome, or obesity. Paradoxically, low SHBG can coexist with low free testosterone in severely obese men due to the loop we discussed in a previous video. Here, improving insulin sensitivity through weight loss, resistance training, and dietary changes, the same interventions that reduce visceral fat, is the primary approach. Step 3. What about supplements? Boron has one frequently cited study from 2011 in which 8 healthy men received 10 milligrams of boron daily. At 6 hours, after supplementation, SHBG decreased significantly and free testosterone increased. However, this was an acute effect in 8 participants. A separate study in bodybuilders found no significant effect of boron supplementation on testosterone or body composition. The evidence is preliminary at best. Milk thistle and dandelion root have liver protective properties in some clinical contexts, but no human study has demonstrated that they lower SHBG or raise free testosterone. Recommending them for this purpose is not evidence-based. Magnesium supplementation has shown positive associations with testosterone in observational studies, and one small trial showed increases in free and total testosterone. However, the effect is likely mediated through correcting deficiency rather than a direct SHBG lowering mechanism. The honest answer is that no supplement reliably lowers SHBG in a clinically meaningful way in well-designed trials. If free testosterone is genuinely low and symptomatic, the evidence-based intervention is medical evaluation and potentially testosterone therapy, not botanicals. Step 4. Understand the full testing panel. When evaluating testosterone status after 40, a comprehensive panel includes total testosterone on 2 morning draws, calculated free testosterone, SHBG, albumin, the hormone that tells your testes to produce testosterone, the hormone that supports sperm production, estrogen levels, prolactin, TSH, complete blood count, and a comprehensive metabolic panel. This gives your physician the data to determine not just whether testosterone is low, but why, and whether the cause is primary, meaning testicular, secondary, meaning pituitary or even functional, related to obesity, medications, or illness. Here's what to take away from this. Free testosterone is a clinically meaningful measurement. It correlates more strongly with symptoms and physical function than total testosterone, especially in men over 40 with changing SHBG levels. But it's not being hidden from you. It's the second-line test in a rational diagnostic pathway. Your role is to understand the system well enough to advocate for complete testing when your symptoms don't match a normal total testosterone result. And your role is to recognize that SHBG physiology is complex. It, Tisha, is not simply a thief that can be neutralized with a botanical supplement. If your free testosterone is genuinely low and you're symptomatic, that's a real medical finding that deserves real medical evaluation. Don't settle for a supplement. Settle for answers. Every study we reference today is linked in the description. You can verify all of it yourself. If this helped you understand your blood work better, share it with someone who's been told their testosterone is fine but doesn't feel fine. Subscribe. We cover men's health with the evidence most channels skip. This content is educational and does not constitute medical advice. Hormone testing and treatment require individualized evaluation by a qualified physician. Do not start or stop any treatment based on a video. In the next video, we'll cover the 5 daily habits that silently lower your testosterone, and most of them have nothing to do with the gym or what you eat.